Should we just record? Yeah. Thank you. Right. Okay. So got everyone here, I think. Yeah, most people. Good. Okay. So welcome everyone. This is the prescribing safety mock test. My name is Yazan. I'm one of the founders of Quesmed, and today we'll be running through a introductory sort of tutorial about how to go through the PSA, how to prepare for it, some top tips, and then go through a mock test of 20 questions to just give you an understanding about how the questions are going to look like, how to think about the stuff that the exam is going to expect of you and how to prepare for that, and then answer any questions and do a bit of teaching as well, which hopefully will be useful not just for the PSA, but for finals for those who have them as well, and just generally being an F1, to be honest, as I found. So who am I? So I am, as I said, one of the founders of Quesmed. I qualified from UCL 2016. I did neurosciences BSc, which was one of the reasons I wanted to start Quesmed, because I really liked cognitive neuroscience, psychology, and also med ed. Did a PG cert, went to North Central London for my foundation, and did well to get into IMT. So I should be doing an IMT application tutorial in the next couple of months for those interested later on. And then now I'm a medical registrar as an IMT3 at St. George's Hospital in South London. So if you are based in St. George's, please come say hello. Cool, so that's me. So telling you a bit more about Quesmed. So we think we are the closest questions you'll find to your written exams, because we felt one of the reasons we started it as finally medical students in 2016 was because we felt that current questions weren't as relevant to exams. So we tried to make better questions and also develop a fairly sophisticated system of notes and flashcards and videos to try and sort of make learning more efficient. And then, so we currently going to have 6,000 clinical questions by this week with a new mock test, which is 1,000 questions. We have basic science questions, flashcards, our quest book, and then the mock tests, which I'll tell you about in a sec. And then our video tutorials, which have been very popular as well in the past year. So our new mock test feature, which is very exciting, is an ability to have mock tests on the site. And basically it's 100 question finals mocks, 4 PSA mocks, and 2 core clinical mocks, which are sort of slightly more for sort of younger years trying to understand clinical medicine, but also for those who are trying to sort of revise the core clinical concepts. So that hopefully should be up in the next few days. Just to show you a bit more how it's going to look like. So you go onto the site and then you can sort of review. I've attempted these, for example, and I've continued these. So you'll have finals mock tests and then the PSA mocks as well. So hopefully this should be useful. And this is free for Quesmed users as well. So hopefully, and I don't think there's anything quite like it in terms of the scale. All the questions are unseen, so they're not on the main question banks. They're all new and they're specifically made to be like finals and like PSA. So hopefully that's useful. And this is kind of how it will look like. So you have this sort of case presentation, which is similar to the PSA, and you have maybe 1 or 2 questions depending on the actual type, and then it will look like that. So that is how our mock test will look like. And then one last thing, which hopefully should be released in the next month, is our new OSCE practice application. Basically, it is an application that allows us to go through mark schemes with your friends, even as groups, where you can sort of join together in one lobby session, and you can sort of go through questions together and sort of develop your OSCEs in a much more structured way. And the one aspect of it we found that lots of the mark schemes that are currently available are not challenging enough, and they don't really reflect the exam, because the exam has lots of twists and turns. So we try to replicate that in our stations. And we've developed around 150 OSCE stations. So hopefully that'll be useful. And that's going to be available via the web platform and also via the app as well. So hopefully this will be useful. And we're also working on OSCE videos as well to highlight key aspects of both examination and less commonly seen, actually, the communication skills, which I think some people do stumble on sometimes. So hopefully that'll be useful. So that's coming next month, we hope. So we'll let you know. Okay, back to the reason you guys are here. So the prescribing safety mock assessment. So prescribing safety assessment mock test, that's the right word. So to start off, we'll record this. We'll put this up on our YouTube channel. So if you go to Quesmed tutorials, which I put up the link, and then question 2 is that you will get the slides. So I think slides are here. Yes. So if you want to just use the bit link, and then okay, so Okay, so what are we doing? So let me just put this on. So bit.ly/PSA. Is that right? No, sorry, it's obscuring. /Quesmed PSA mock test, just so that for those who aren't there. So I'll just give you like 30 seconds to sort of go through. Cool. I'll answer your questions shortly. And then, yeah, cool. Okay, so someone's asking, so just while everyone puts it up, so when will this go up in the next few days? So the mock test will be available for anyone who has a subscription. The OSCE will be a separate subscription. Thank you for appreciating our social media, which is top feature. Brilliant, thank you. That's thanks to our social media team. And then what have we got as well? We have, does it change significantly year? Not significantly. Go UCL. Woo. And are the mocks included in general Quesmed subscription? Yes. Do we need to pay extra for the OSCE resource? Yes. Okay, fine, good. So answer some questions. So I hope that everyone's got that. So why did you do the PSA? One of the reasons they started the PSA was because they found that the people that write the most subscriptions are FY1 doctors, and they have a very high error rate. However, you can interestingly see on this graph, this is one of the graphs they have on the PSA, sorry, on this table, got 8.4, and you have 10.3% for FY2, 8.3% for others. I don't actually know who these people are. I think they're trainees. And then consultants have a 5.9% error rate. But you can see as a denominator, the number of prescriptions written by FY1s is about more than 10 times more than a consultant. So therefore, it makes sense to make sure that F1s know how to prescribe and know the sort of high risk stuff, which is kind of why it's all about safety. So few points about it. You need to pass it before you prescribe. It's designed for final years. It's delivered online, and you have access to the BNF throughout. And then it relates to outcomes for graduates 2015, which is sort of, again, this idea that you have a number of outcomes you need to achieve as a final year medical student to become a doctor. This is one of them. And then it has some skills, it has some deductive powers, and also just knowledge that you sort of pick up throughout your medical training / revising. So yeah, so you need to make sure to be able to write a safe and legal prescription. You have to be able to critically appraise the prescribing of others, which is very important, because when you start a ward round, you're looking at the person that was on the ward round the day before to make sure they're doing everything right and whether or not you need to change. Common conditions are very important. You need to know how to provide the appropriate information, calculate the medication doses, monitor efficacy, and then report drug reactions. So yeah, this is sort of how the sort of all the different sections sort of come together. And on this next slide, you'll see that this is the general breakdown. So you have different sections that have different elements of what I was talking about earlier. And then it's all sort of mapped out according to not just the elements, but also the high-risk drugs, as you can see on the left, opioids, anticoagulants, insulins. You can see that if you give opioids incorrectly, anticoagulants incorrectly, it can lead to lots of issues. And these are the ones that people end up having more datexes, for example, and also sort of, it's the thing that people struggle with the most. And finally, it's also mapped according to specialty. So you need to make sure to revise not just medicine, but also pediatrics, psych, ONG, and GP as well. So that's kind of the general view of things. This is, again, the breakdown just for your reference. And then today, our mock test items, I've tried my best to put it up on the, just to sort of make it as variable as possible to give you a flavor of how things work. And again, this is all on the PSA website. And again, you have these sorts of high-risk drugs here on the right, and then you have this minimum number of items on the exam in the exam itself. So medicine, surgery, pediatrics, et cetera, et cetera. So you have to make sure that you're covering all your bases when you're preparing. So again, even reviewing the sort of final Z bits is relevant itself for pediatrics and psychiatry. At my medical school, for example, when I was there in 2016, we didn't have pediatrics and ONG in our finals. We had a bit, but like it was mainly done in the year before. So I had to go back and revise things. So I would recommend that you sort of consider it slightly final Z in that context if there's stuff you haven't been through for a while. So my suggestions for revision. some of you who use Quesmed will know that for some reason, I don't know why, lots of people, this phrase has been bandied out about a lot throughout the platform, spend more time in the wards. And I think it started as a bit of a joke and then it just sort of kept going. But I think it's very true. I wasn't the one who started it, by the way, but I have seen that people use it a lot. But I think it's really true. So for example, when I'm with medical students, always make sure to sort of go through prescriptions and say, why do we use this? Is there a reason we're not using that? Is there a particular reason that we want to use this instead of that? So I think when you are a medical student and you're on the wards, I think it's very important and very useful that you're always sort of questioning things and you're watching the F1s and the F2s and the SHO and the CT1s prescribe. And if someone's starting a sliding scale, just look at what they're doing and just really ask them questions. Why are you prescribing a sliding scale? Why are you not prescribing a fixed rate? And just having that sort of how do I say, the sort of deductive element to it. So when you're saying, okay, we're using this because we're using that, and therefore this is going to happen. So that's really, I think, and this is true for finals as well, I would say, just having this clarity of thought in your head is sometimes very important, and you can actually use it a lot on the wards to learn more. That's what I would suggest. Also doing practice questions, I would recommend. I think the PSA, if I'm not mistaken, still have mock papers. I think last year they did. I think they might do this year. And then in terms of reading, the Bnf is very good. It's very detailed. There's lots of stuff to put in. There are some really good summary sections in the Bnf, which I would recommend. There is a book called The Pocket Prescriber, which I used a lot in medical school, but I think it might be slightly out of date, but still relevant. And then obviously things like the Oxford Handbook for Emergencies is very helpful, and just generally sort of nice clinical knowledge summaries, et cetera, because sometimes, not always, things are very guideline based, but the likelihood is that they won't ask you about detailed guidelines, but it's just sort of knowing the rough sort of guidelines in terms of how it works. So that's what I would sort of recommend in terms of preparation in a nutshell. So what we're going to do today, we're going to go through the mock test. So we have 20 questions, which I'll give you a minute and a half each. That's 30 minutes. I hope I've done the math right on that. Tell me if I'm wrong. And then we will review the answers. We'll do some teaching about each of the questions. And then we will, if you have any questions, the chat, and we can discuss at the end. And then we'll get some feedback off you, please, if that's okay, because I would like to know what you guys think. What do the questions look like? This is kind of how it's going to look. So you've got on the left-hand side, the blurb. And then down here is the prescription request or the actual sort of action point. And then you have certain elements here. So it ranges between adding things in and sometimes SBA type stuff. And there's tick boxy stuff as well. So what I would suggest is, sorry, I'll go back to that. Having a pen and paper ready now, if you want to get that, so you can jot down your answers, and you can go through it later on, so you can tally up your score. Again, don't read too much into it. It's just a sort of general idea about how things work. And then a friendly reminder: these are some of the abbreviations that we use, which I hope for most of you should be very understandable. I guess the only one which you may not have used so much is the one at the bottom, which is stat. Obviously you might have heard, but once off for once only. I guess it makes sense, but I don't think I had come across it early on. So yeah, otherwise I think hopefully OD, BD, TDS, QDS by now should be fairly straightforward. And is inhalation. Okay, cool. So do you want to get pen and paper ready? Let's take some questions just before we start. So someone's asking, does each section of the exam have a time limit or no? So the time limit is to complete the exam in total. So yeah, so I think the way it works is that you have some questions that will take longer time and some questions will take less time. So like the SBA stuff, I think the SBA style questions take less time, whereas maybe the prescription form stuff, I think takes a bit longer. I think in the interest of time for us for this mock test, I've sort of given you a minute and a half for each, but in reality, you might spend more on one question and more on the other. So for example, the answer might just be a very simple, as if you're doing a multiple choice question, but then sometimes you have to sort of read through the BNF and go through stuff. So, but I guess just in the interest of putting it all together, I think, yeah, we'll keep it together. So do you have access to the BNF for all Qs? Yes. And then you can use the online NICE BNF. I believe you can use the online NICE BNF if I'm not mistaken. because I think it'll be difficult to have everyone have the book. Yes, you will have access to recording. Yes, as I said. So yes, it'll be on our YouTube channel. So everyone has the slides, I hope. Yes, maybe. Okay, good. And then everyone will have the recording. Okay. If anyone asks in the chat while I'm talking later and I don't see it, please let them know. I think it's just the BNF you guys can use, as far as I know. And I don't actually, so when I did it, it was actually at my medical school in the computer room. So I don't know how they do it for you guys. So I'm afraid I don't know the technical aspects, which I should really know, but I don't, I'm afraid. But I will find out for you. And then I can add it onto sort of any email we send to you later on, if you like, if you want to know stuff. Pearson, yes, same idea. I'm not surprised. Okay, fine. So if there are no other questions, I think we will start, if that's okay. So I'm going to stop my video now. And then can you use Control F to find words on our BNF? I think you probably can, to be honest. I don't see why not. Cool. Okay, fine. So let's start, guys, if that's okay. So start of mock test 1. Oh yeah, last year we ran 3 different mock tests, but now we don't need to, which is good. So well, do you want me to talk and say next question? I was wondering last year I did that, or would you prefer I just move on? Okay, next question. Fine. Okay, I will do that then. Cool. Okay, so let's start. Everyone ready? Any other questions? Fine. I don't know what the medicine's complete version of the BNF is. I'm sorry. Anonymous attendee. Okay. And then, right. So question 1, starting now. Okay, question 2. Question 3. Question 4. Question 5. Question 6. Question 7. Question 8. Question 9. Question 10, almost halfway there. Question 11. Question 12. Question 13. Question 14. Question 15. Question 16. 5 questions to go. Question 17. Question 18. Question 19. Question 20, final question. Okay, everyone, so that's 30 minutes, end of the mock test. Well done. All right, so let's just take a few minutes to gather our thoughts, go through any final questions. How did you find it? Hard, easy, mix of both? Yeah, let me know in the chat. I think last year people found it, some people found it quite hard, I think, because maybe they hadn't looked through a few of these things for a while. So we shall see. I want to show you something actually while you're all here. I think, let me get it up. Let's take that. So I think one of our developers has been working very hard to get a viewable mock test version ready, so I can show you if you're interested, of course. So this is what the mock test is going to look like. So hopefully when it's released in the next few days, we hope. So these are the finals mock tests, so 100 questions, and then these are the PSA mock tests. So yeah, these are just the first couples. I think if I add that, this is kind of how it looked like. And then you sort of see, we just need to clean a few things up so it looks good. These are sort of the same sort of style that you have. And then, yeah, just to show you kind of how it will look like. And yeah. So, and then, yeah, equally the finals ones for those of you who have finals. And then do the finals, blah, 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 if it starts, then you can go through questions and then you can review, blah, 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 you can look at the flag and complete, and then you can finish your mock test and then you can look through stuff and then you get a passing score as well. and you can sort of review stuff in the same way. And you can look at the quest book. Very exciting. And then you can make a comment. Or not. Okay, cool. So yeah. Hope that is interesting. Let's get back to business. So back on that. So share screen. Cool. Any questions? Okay, so okay. The fiddly looking stuff. Yeah, so this is just kind of practice, isn't it? I think I don't know if you can control F and the. I think it's because it's in different. Just technically speaking, they're all in different like sheets. So I think you can only look through like one page. So maybe if you go to the summary page, you can control F. Then I think that should be fine. So yeah, a bit harder on paper writing. Yeah, it's fine. Function is introduced hopefully in the next few days. Insulin hurts my brain, and then questions where you fill out the prescription. You don't get the marks unless you fill in all the blanks. I think you get points for the number of blanks you fill in, for example. Yeah, fine. Right, so cool. Okay, so let us start with the questions and then we can go through the answers. And if you have any questions, I think I'll do all the sort of question stuff at the end, if that's all right. Okay, fine. So first question, prescription review. So this is a 27-year-old with abdominal pain, vomiting, polydipsia, and polyuria. You can see one of the most important aspects of the case is that he has a low pH and he has a high glucose and high ketones. So then you're thinking, is this diabetic ketoacidosis? And therefore, after you give fluids, how do you manage the high blood glucose? So this is the answer. You give a dose of insulin as an infusion at a rate of 0.1 units per kg per hour. And this is one of those things that you just have to sort of memorize, that this is the sort of normal rate that we give things for. So in this case, for DKA, that is, he is 75 kilograms, and therefore we want to give him 7.5 units per hour, IV or IVI, once off, continuous, and then you put your initials or your name, and then you date it. And you'll get points for putting this stuff. So it's easy points, really. So just putting whatever. I think it should be straightforward enough. I guess this was sort of more in the past where people had paper prescriptions and people would forget to put their initials. But in the days of e-prescribing, obviously things are a bit different. But it's very important still to make sure to keep the tradition in this context. So going to DKA, which is very important both for exams and for your foundation years, you need to ensure that the first thing you do is to resuscitate because people are very dehydrated. And then you correct the hyperglycemia and acidosis with insulin on a fixed rate, not a sliding scale. The fixed rate, the idea is that you're pushing loads of insulin to try and get those ketones out and therefore resolving the acidosis. Whereas a sliding scale, you're sort of trying to just balance stuff to make sure that you maintain between a certain blood glucose. Whereas this is really pushing in insulin as much as possible. And then when it gets really, really low, you add on dextrose to sort of make sure that you don't become too hypoglycemic, which can be dangerous. And then if you have hypokalemia, you should also correct it because insulin can cause hypokalemia. So in the first hour, you tend to give IV saline or a fluid challenge if the systolic is low. After commencing fluid, you start on the fixed rate insulin infusion, and then you have all these observations for glucose, ketones, GCS, and ECG monitoring. And later on, as the potassium will likely to go down, you will then start giving lots of potassium. It does not really that necessary for you to know the exact hours, for example, because it changes according to each local guideline. However, there's a really good guideline by the Association of British Diabetologists online, which is very, very good, which you can use to look up DKA as a national guideline. And then other stuff to do just for what it's worth is catheter as well is very important. And then, yeah, just monitoring things like as we said, the monitoring stuff we talked about. So yeah, that is roughly how you would manage DKA, and that's how you'd answer that question. Looking at question 2, we have a 19-year-old gentleman who's come in with shortness of breath and wheeze. Wheeze is heard throughout. They are Are they hypoxic? No, they're not hypoxic, but they're very wheezy. And their CO2 is a bit low, which is expected in what we think is going to be an asthma attack. So how are we going to treat this gentleman's bronchospasm? The answer is usually salbutamol, of which you can give 2.5 to 5. The respirages have told me that there's no significant difference between 2.5 and 5 sometimes can cause tachycardia because that is one of the side effects of salbutamol. So usually 2.5 is your best bet. If you look at the BTS guidelines, they say you can use terbutaline. I've never seen this, but it technically is correct as an answer. So yeah, you could use that. But again, it's a bit niche. Salbutamol is what we use and will be also the correct answer. It's very important in acute asthma, as you might know, is to give people nebulized salbutamol and ipratropium bromide alongside steroids, considering magnesium sulfate over 20 minutes, call intensive care, and then thereafter considering patients on aminophylline, and then whether or not they require ITU care. And thereafter, the main sort of, or during this whole episode, you're monitoring their SATs, monitoring their peak flow, making sure that they sort of don't have a life-threatening attack where they sort of have a silent chest and they can't speak at all. And one of the biggest issues is that a normal CO2 is very concerning in acute asthma. That indicates a very, very severe attack, and therefore, obviously, in most contexts, you would have called the intensive care team anyways, but it's important to make note of that. It's a very classic finals question as well. Question 3, 51-year-old, urinary frequency, foul-smelling urine and dysuria. Instantly, you're thinking, is this a UTI? Cool. And then you're just looking at the other stuff. Are there any contraindications for what I think I should give? So you're giving cotrimoxazole. So they're allergic to cotrimoxazole. And what else have we got here? Hematuria 1+, cool. Urinary MCNS. So you're writing a prescription for one antibiotic that's most appropriate. And in this case, it is nitrofurantoin, which is immediate release or modified release, and usually for 3 days. The reason you don't give trimethoprim in this case is because it has the same active ingredients as cotrimoxazole, which she is allergic to. So it's either nitro or trimethoprim. In this case, you would give nitro, which is for 3 days. But if it's a man, you usually give it for longer, 7 days, and also women who are pregnant. And also the first-line antibiotics change if you're pregnant, so I might as well look into it. I believe, if I go to the next slide, nitro and amoxicillin are first line in pregnancy. I don't think you give trimethoprim. I think it's because, if I'm not mistaken, it might be related to folate dysfunction, if I'm not wrong. But antibiotics used in UTI, of course, there are many. So one of the issues with trimethoprim is that it can lead to a elevated creatinine because it also inhibits tubular secretion, which is, again, another classic finals question where you start someone trimethoprim and their creatinine goes up. What's the likely cause? It's the trimethoprim, not an AKI. On the other hand, nitrofurantoin doesn't work very well in patients who have an AKI. So if you have low EGFR, nitrofurantoin is contraindicated. The other medications, which, as you can see here, pivcinlam, fosfomycin, amoxicillin, cefalexin. And then on the bottom left, you can see some other classic complications or issues that you have. Gentamicin, auto and nephrotoxicity are commonly, I wouldn't say, maybe not autotoxicity is common, but it does happen, of course. But these are the things that are associated with gentamicin, and you need to monitor gentamicin with a level. Ciprofloxacin is associated with C. diff infections, prolonged QT intervals, so it's good to do an ECG, and also very niche Achilles tendinitis. And finally, comoxiclav can cause a lot of things. It's a penicillin, so it can cause anaphylaxis in people who are penicillin allergic. It increase the risk of cholestasis with your sort of ALP going up and your bilirubin going up, and it can cause sort of GI upset, diarrhea, vomiting, etc., which is true for most antibiotics, to be fair. But it's just something to be aware of in prescribing penicillins as well. Okay, prescription review. So I think this is one of the hardest sections because there's so much data, so much stuff you have to go through. It's very hard to actually go through it in very sort of very quickly, basically. So I think this is the next question. So we have a gentleman with chest infection, and there's a rash on his ankles, weight is 70. What's the most likely cause of his pancytopenia? And then which prescription has a serious dosing error? So Basically, tacrolimus is a medication that is used for patients who have renal transplants or transplants in general. And it is a lot of the immunosuppressants, a good number of them can cause things like pancytopenia. So you need to be very worried about this group of patients. You need to make sure to check their blood tests quite often. And then equally, the next thing is very important is I think quite hard actually for sort of F1. I think some of the questions will be hard because they want to make sure that not everyone's getting 100%, 90% or 80%. You have to have some very hard questions. So in this case, it's such a tiny detail, but it is relevant. So in this case, it's the tazocin. It's 4.5 milligrams grams rather than milligrams. And, it's one of those things, again, if you spend loads of time on the wards, not to sort of really hit home the point, you will probably maybe pick up the fact that, yes, maybe the tazocin is not the right dose. But again, like I probably didn't realize this until I was maybe an F2. But it's one of those things where you spend more time with doctors, et cetera, you will pick it up. But very, very unlikely to for the vast majority of people because it's such a detailed niche thing. Some immunosuppressive stuff. Cyclosporin can cause gingival hypertrophy, some hair growth, nephrotoxicity. Tacrolimus can cause loads of stuff, as you can see here. I think clinically speaking, the one I see the most probably is tremor. And then it can also cause pancytopenia, as we discussed. And then mycophenolate can cause a GI upset and myelosuppression. And here on the right-hand side, you can see the side effects of corticosteroids, which I really like mnemonics. This is a really useful mnemonic for me, corticosteroids. So use it if you like. If not, then that's cool. Fine. Okay. So question 5. So we have someone who had a left side nephrectomy, not being able to open his bowels, 65-year-old. 3 medications that are likely to cause constipation, and then the one prescription that is most likely to be contributing to his fluid retention. So looking at the answers here, the most likely cause of his constipation is likely to be the opiates, as you might expect. So it's tramadol and morphine sulfate. And the other one, which is less commonly so, or less commonly recognized, is ondansetron. That's another cause. And then the other stuff really doesn't really, like salbutamol, not really, protopium, not really, tamsulosin, paracetamol, and senna does the complete opposite. So, and then the fluid retention is prednisolone, which, again, corticosteroids can cause a lot of stuff, which fluid retention is one of them. But again, in clinical practice, I feel like, well, the one cause of fluid retention I see really frequently and might be examined is amlodipine, which is one reason why there's max of 10 milligrams, but some people just can't tolerate it. So they just go down to 5, for example. So that's one thing to remember, amlodipine. So just briefly on constipation in the elderly, do PR them. Jerry's consultants want you to PR patients. Cool. It has its role in figuring out whether or not patients have evidence of stool or an empty rectum, and whether or not they're obstruction or not, et cetera. So the big meds are opioids, anticholinergics, antidepressants, and then treatments tend to be things, as you can see here, bulk-forming laxatives like Aspergilla husk. You have osmotic laxatives like Movicol, stimulus laxatives like Senna, and then you can give sort of rectal stuff like glycerin suppositories or an enema. And the way we usually do it is Movicol, we sort of do it, they're like sachets. So we give them twice a day, and then Senna is usually once a day, once at night. And if you're unlucky enough to be an F1 on GI, sometimes you get asked to do a manual evacuation, which is not pleasant, but hey ho, sometimes F1 is not very pleasant. Yeah, so these are generally the sort of things that you do in people who are constipated. Cool. Okay. Question 6. So again, we're looking here at a patient who's had a surgery. You are asked about 2 prescriptions that should not be co-prescribed, and then the 2 prescriptions that are most appropriate to withhold until the renal function recovers. And in this case, the answers are paracetamol and cocodamol, because they both have paracetamol in them, so you shouldn't prescribe them together. And then the renal failure is you shouldn't give cocodamol because codeine can accumulate in renal failure. So you shouldn't give that. And ibuprofen, generally NSAIDs equals bad. So especially in AKI, because it can worsen your AKI. So you need to stop that. If you'll see this a lot in palliative care. So the palliative care nurse will come to you and say, hi doc, did you realize that this patient has renal failure and you gave morphine? And then you'll say, oh, really? Oh, I didn't know that. And then they'll say, yes, this is wrong. This will accumulate. You need to give oxycodone. So you'll learn this on the job very quickly, but it's good as well for exam, just in case it does come up. Okay, section 3, planning management. So what do we have? So hopefully these ones are, as you can see, the first couple of questions were a bit more sort of dense. These ones, perhaps you might sort of figure out fairly quickly. You know, you've got someone who's got shortness of breath, chest pain, bibasal creps, pitting edema to the buttocks. Is this heart failure? What do you do next? The correct answer here is furosemide 40 milligrams IV, which is the first line treatment. CPAP can be considered later on. Digoxin is not really a treatment for acute heart failure. GTN spray, GTN infusion can be used later on, but on the first instance. And then morphine sulfate has mixed efficacy in terms of the use in heart failure. It's not some, I think there are some studies that have shown increased mortality using it, but some have not. So I think you can use it for pain, chest pain, definitely in this context, but generally you're going to give furosemide, aren't you? I don't think we usually, I mean, from my experience, we don't usually give morphine in terms of just for heart failure itself. So yes, this is the stuff you would give. So oxygen, diuretics, nitrates as an infusion later on, and then you can consider other stuff like CPAP, continuous positive airway pressure, inotropes, which help to increase the blood pressure if needed, and then furosemide infusion. And then you check the renal profile regularly and the weights as well to make sure that the patient is offloading. Okay, next question. So you have someone who's got a follow-up appointment with the GP. They're on up titrated all the way on metformin to 500 milligrams PO/QDS. Their HbA1c is still high. What do you give next? The answer in this case is gliclazide. So basically, you just need to know that metformin this is the maximum dose. So it's good to sort of maybe have in your head what the maximum doses are for the commonly prescribed medications, of which metformin is one of them. And then when that's not working, you usually start gliclazide. And then the other stuff doesn't really work because it's kind of, this is above the maximum dose. This is basically the same because it's, 2 grams anyways. And then this is incorrect because you should really start gliclazide first. This is a handy diagram written by one of our editors. I think it was one of our editors. I found it very useful because it just puts through everything. I think the main difference between metformin and gliclazide is that you don't get hypoglycemia in metformin after metformin use, whereas you can with gliclazide. So those are the key distinctions. And then metformin can cause a lactic acidosis. Pioglitazone is another one which you can use. It's contraindicated in heart failure and bladder cancer. And sitagliptin, it's sort of insulin. It sort of imitates insulin to a certain extent, increases insulin secretion. And then the only other important one, which is the dapagliflozin, which has increased risk of UTIs and Candida, but actually reduces mortality in heart failure independent of diabetes, according to a recent study. And then, those are the main things for insulin. I think I haven't actually put any questions, if I remember, on insulin, like how to actually prescribe and do stuff. So I think there are some questions on the mock tests on the website about it, but I put them on for time reasons. So cool. Okay. So question 9. So you have a woman who has pain in her left breast. She's 6-week postpartum. She has erythema of the breast, warm and very tender, no nipple fissuring or fluctuating lumps of palpation. What do you give next? And the answer is Fluoflox. Anything that's like skin cellulitis sort of thing, usually we give Fluoflox. Not always, but most guidelines will tell you to give Fluoflox. So a good rule of thumb is if you're not sure and it's a sort of cellulitis type thing, it tends to be Fluoflox. And it just happens that guidelines say Fluoflox for lactational mastitis, which makes sense. So this is one of those things where the general principle you can use, but also you can know the guidelines. So it's, but the general principle I think is more important, arguably, because you can apply it to different things, whereas a guideline, you just use it for the guideline. Okay, So I think, is that question 9? All right, let's just go through some questions. Let's see. Okay, let's see if there's any important questions. Okay, let's go through this at the end, actually, because it's fairly general stuff. Okay, question 10. So this is a question about someone who's using GTN. So the question is, what do you tell the patient? So this is a type of question that you can encounter as well. And the answer is GTN spray may cause headache. So GTN spray doesn't increase the risk of oral thrush. That tends to be things like salbutamol, sorry, not salbutamol, prednisolone, the steroid inhalers. The way that we, in terms of the ambulance stuff, you basically keep, you repeat the dose at 5 minutes intervals. And if the pain is not gone 5 minutes after the second dose, then you call an ambulance. So that's what it is. And then GTN should be sublingual, so straight under the tongue, not into the tongue. And then, yeah, so the same applies for the information. It's very important. So this is sort of, do you know how to speak to patients in terms of how to advise them on their medications, which is important. So you have someone here, question 11, who has weight loss, excessive thirst, and frequent urination. So you want to start insulin for diabetes, and then you want to tell them more information. So what do you do? So this is what you tell them. So she should continue her long-acting insulin during sickness. So similarly to things like steroids, if someone is unwell, you need to make sure that they keep having the insulin during their sickness because the body will need more insulin, basically. Looking at the other options, she should inject insulin at the same spot. No, she needs to rotate, and because it can lead to disruption of the tissue at the area. You should store the insulin in the fridge, not the freezer. Insulin causes weight gain, and insulin very much causes hypoglycemia, which is why it is one of those high-risk drugs which you need to know how to prescribe correctly. Okay, calculations. I think this is the one that people are a bit more afraid about, maybe for those like myself who are not so math savvy. Maybe some of the questions are a bit more kind of common sensey. Others are, knowing certain aspects of calculation. So I've put a couple of representative questions to show you. I don't really want to go through the nitty-gritty of the calculations because I never found someone walking me through calculations to be so useful, but I will try. But basically, you have someone who was given 20 mg an hour of labetalol, yeah, and then in 0.5 hours, so for 30 minutes, and then that's 10 milligrams. And then she had 40 milligrams an hour for another 30 minutes. That's 20 milligrams. And then she had 80 milligrams an hour for 15 minutes, 20. You just add them all together. Hope that makes sense. So this is one of those questions that actually doesn't need any medical knowledge. It's just calculating stuff. It's very interesting, actually, because sometimes when you're on the ward, the nurses are like, and they kind of second guess themselves a bit. And they're like, oh, should I, is this the right dose to give? What do you reckon, doc? And you're like, I don't know, I've never made up labetalol. And so you kind of sort of help out and you understand the problems that they have in terms of developing, and you begin to develop a more holistic view of healthcare, which is very important. So perhaps that's why it's in. And sometimes, I suppose back in the day, you would have to sort of put it together, but not anymore, obviously. But yeah, that's why this sort of question is in here. Next question is pediatrics. I'm not going to pretend I know anything about pediatrics because I'm a medical registrar, but this question was written by one of our editors. So I put it in just to sort of show you a very important point, which is basically about fluids in pediatrics. And I will talk about adult fluids afterwards, just now, to show you kind of where we're going with this and what you should, the resources to use. Okay, so there is a guideline which is fairly straightforward, which I'll show you now for the next station. If you look here, so this is the NICE guideline NG29, and it tells you about if it's a person or young child, you have this formula, holiday cigar formula, which is 100 milligram per kg per day for the first 10 kg, 50 mil per kg per day for the second, and then therefore 20 over 20 kilograms. So if you know this formula, and then it becomes very straightforward because literally you've only really got two things to sort of figure out. So you got the first 10 kg, the second kg, you have the kg there, you sort of just put it all together. and then the remaining 20 is 160. And then it tells you to remember, same as sort of A-level math exams, I remember you sort of remember what the units are. So it's mils per hour. So you divide by 24. But again, this is something you can look into, but I'm just trying to teach you sort of the main principles behind it. And so that's the NICE guideline, which you can look at. There is another important aspect, which is for fluid resuscitation in adults, is that you need to, if you are giving lots and lots of fluid boluses in adults, there comes a point where you need to think, okay, once you give more than 2,000 mils, you need to seek expert help and need to consider whether or not this patient needs further treatment in an ITU type setting, which is fine. So this is the same sort of guideline, not that much that's new, I suppose. The only extra thing, which, again, sorry, this is sort of a lot of information, but I sort of like to put it up so that people can sort of come back to it later. But in the past, when I was a medical student, loads of SHOs would sort of quote this 2 salty, 1 sweet thing about how much we need to give in terms of fluid maintenance. Yeah, because everyone would always be a bit sort of flabbergasted by what fluids we need to do. But there's very good, nice guidance on this, and you can look into it today. So for example, here on this right-hand side, it tells you this is how much water you need per day, this is how much sodium you need per day, and this is how much glucose you need in a day if you're not eating or drinking anything. So if we were to look through it in a 70 kg man, let's say, the requirement is 2,100 and then 70 milligrams of sodium potassium. And then you just need to remember how much is in each bag. So glucose has 50 grams, sodium chloride has 150 millimoles of sodium chloride. So basically it kind of works out with 2 to 3 liters of fluid a day. And usually you give sort of the potassium as well in it, because that is, you need to make sure, sorry, that's me. You need to ensure that the potassium is replaced as well. So I think, so on the most part, what you end up doing is you probably do, I think 2 salty, 1 sweet actually kind of works as a mnemonic, but the actual nitty gritty of it, really, you can use the sort of NICE guidelines. But again, a lot of it is just sort of, it is a bit of an art, I think, because you have to then use this and think about your patient in front of you. Are they dehydrated? Are they not? Do they need more fluid? Are they overloaded? Blah, 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 blah. So actually, that's why it's confusing, because there's no real guideline apart from the guideline, which is why I believe truly that we need to focus on clinical reasoning and understanding our patient in front of us rather than just sort of reading through a guideline. But again, that's maybe more for your foundation years, but keep it in mind for the future. And this is the actual big guideline, so you can look into it later, just so you can have a look at it. Again, NICE guideline 174, and this is why I put it up here. Okay, again, this is another calculation question, pediatrics, which is again not my specialty, but just to sort of show you the rough sort of question that you can get. In this question, a lot of it again is one of those things, if you have spent some time in the wards, you sort of have seen doctors prescribe amoxicillin. I haven't seen anyone prescribe amoxicillin for maybe 6 years now, but basically, from my understanding and speaking to our pediatrics editor, this is it's the normal dose is 500 3 times a day. You can increase it to 30 milligrams per kg 3 times a day, which is about 1,000, so 1,050, but you have to have the maximum of 1 gram per dose. So the maximum dose is 1 gram times 3 a day, which is 3 grams. So remember, always read the question. You guys should know this by now. How much can be given per day? So therefore it's 3, not 1. So a bit challenging, but pushing you in the right direction, hopefully. The next type, section 6, is about adverse effects. I think actually we could put out the feedback form now, if that's all right, so that the last few questions, if that's all right, Shankari, so we can, so that we don't get mixed up later. Thank you. What have we got? So adverse effects, and you will have adverse effects that are caused by the treatment or the sorts of interactions or the management for an adverse reaction. So looking at this question, we have a patient who's on rivaroxaban, and they have listed on the right, which of the following is most likely to interact with rivaroxaban? And the answer is indomethacin. And again, a very good rule of thumb, which I use a lot, is NSAID equals query bad. I'm a very simple man when it comes to these things. So if you see NSAID, always say query bad, and then it may be bad, it may not be. But most of the time in an elderly patient or someone who's on loads of medications, you need to look into it in a bit of detail. The other stuff doesn't really interact in that much detail. I suppose in theory, ramipril can cause a AKI, which then is bad because indomethacin as an NSAID can cause it, can be associated with worsening of your AKI. But in this case, there is no AKI in the question. So yeah, cool. Next question. So you have an elderly man who's got hypertension, BPH, epilepsy, Parkinson's disease. He's got a blood pressure drop posturally, lying and standing. What is contributing to his orthostatic hypotension? It is tamsulosin, I think. Yes. One of the big tragedies in life is that when you get older, you get things like benign prostatic hypertrophy, and you can also get things like Parkinson's disease. And if you have both, then you're in a bit of a struggle, because the tamsulosin leads you to have blood pressure drops, and also the Parkinson's is not good because it can lead to blood pressure drops as well. So you need to make sure that patients, the polypharmacy is looked after, and therefore tamsulosin is the right answer. In fact, actually, co-caraldopa can cause hypotension, postural hypertension to a certain extent, but tamsulosin is usually the most likely culprit and the thing that you would stop first in any case. Midodrine is a management option for Parkinson's. Just for reference, this is the stuff that we give. We try non-pharmacological stuff: fluid, salt, compression, pharmacological measures, and then fludrocortisone, midodrine. Very poor evidence base for fludrocortisone, but we use it anyways. Midodrine is better evidence, and we sometimes use both together. But a lot of it, actually, the first thing we do is try and stop stuff that can cause postural hypotension. Okay, very good. Monitoring. Okay, last few questions, I think, maybe. Yes. Okay. So this is a classic sort of thing that, again, you can come across, and digoxin. So giving digoxin, how do you then do the level? So in this case, you need to know when the drug was given, so 8 hours. And then when do you give the next? And this is really important, because when you're on a ward round, the consultant asks you to give digoxin and then do a level. They sometimes don't know. It's like, they sometimes maybe forget. So you need to kind of know and to look into it and remember, oh, okay, so given this medication here, I need to know I'm going to do my level there. So the answer here is 2 p.m. And the reason for that is because the rule is digoxin, you do the level 6 hours post-dose. And that's sort of the best way of finding out the exact level, because digoxin toxicity is very dangerous. You need to make sure that you know what you are treating, and you need to know what the level is to make sure that there are no complications. So we talked about, so digoxin can be used for many things. We use it a lot in hospital for fast atrial fibrillation. However, people might be on digoxin chronically for patients who have heart failure and atrial fibrillation, and you need to monitor the potassium in particular, because toxicity can be caused by hypokalemia, because potassium competes with the drug, but toxicity paradoxically can cause hyperkalemia. So that's sort of the worry. And then you can treat it with this monoclonal antibody called Digibind. And here you can see this sort of reverse tick Salvador Dali style ECG change, which again is common in digoxin toxicity, but actually you can see a lot of different cardiac findings. Bradycardia, again, common in digoxin toxicity. Other monitoring stuff, I just put this down, I sort of trying in my head to think about the stuff I see regularly on wards. Heparin infusions, you need to take APTT 6 hourly and monitor the dose. Gentamicin level, we'll talk about shortly. Deltaparin, you check the platelets. Rufusamide, you check the renal profile. Warfarin, we try and get the INR between 2 and 3 for most patients, except metallic valve patients, usually it's 3 to 4. Lithium, we try and aim around the 1, which I can't remember exactly what the dose, the reference range is, but it's usually around the number 1. That's how I remember it, and it has stuck in my head over the years. And then clozapine as an antipsychotic, you need to check the FBC for agranulocytosis. You can also monitor anticonvulsants in patients with epilepsy. I think this is the main stuff you actually need to know in terms of monitoring. I couldn't think of that much else, to be honest. This might not be on your slides actually, because I added them just right before the end. So do take note of it if you like. Fine. Okay, last 2-3 questions. So you've got someone who you want to monitor for adverse effects of the atorvastatin. Hopefully this is straightforward. You might have come across many times before. The answer is liver function tests. And again, liver function tests make sense on principle, but again, sometimes there are guidelines to help us. And in this case, if someone has the key thing that is slightly confusing is that if you have, this is just exactly from the guideline itself. Basically, if it's less than 3 times the upper limit of the reference range, the serum transaminase, you can still keep using statins, basically. But if you are more than 3 times upper limit of the reference range, you should discontinue statin therapy. That's kind of what it is. But again, you can have a look at the guidelines if you want. But again, the general principle is here. And that most people will have, not most people, but there's a number of people who will just have some slight LFT derangement, which is fine. They can continue with their statins. Question 19. 19, yeah, so this is, again, one of those things that you need to, I don't think the actual content here is so important in terms of, the exact nomogram, knowing exactly what the nomogram is, but I think it's just important to know sort of what you would, so don't worry too much about this question. It's just knowing how to interpret the graph. So you'll have some graphs. I think someone asked earlier, I talked about the paracetamol graph, which is very important. So knowing where to find that. In the BNF, there is, I remember, if I recall correctly, there is a BNF paracetamol graph. And basically the way it works, the patient had the first dose of gentamicin given at 4 p.m. and then the serum gentamicin level was taken at 11. So that is about 7 hours in. Yeah. So you want to look through here and say hours between start of infusion and sample draw. So it was 7 hours. Yeah. And then when was it? It was 6. So then you look at the gentamicin. So therefore, you take another level at 24 hours, which is 4 p.m. tomorrow, because that's when this was administered. That's the answer. Oh, sorry. You give the dose at 24 hours. Sorry, not to repeat the level. You give the dose at 4 p.m. the day after. So if I go to the next slide, yeah, so that's how it looks like. I just copied this from, there's a Yorkshire Hartford gentamicin regimen. And this is, again, that's sort of the same idea. So you look at this vertical axis, you correspond it to the horizontal axis, and you say, okay, 24 hours, I'm going to give the next dose in 24 hours. That's fine. And again, this is sort of idea that, okay, lots of trusts don't use this nomogram anymore. What we do nowadays, and lots of trusts, is that you take the post-dose level at 20 hours, and then if low, we give the next dose. But I think the point really is that things can get really complicated. So it's very important to refer to your local guidelines when you start working. But I really, really do believe that it's important so you know how to interpret graphs in clinical practice, because you'll be on a ward round, the consultant will say, start vancomycin. And you're like, vancomycin, okay. And then you go to microguide or whatever it is, the guidelines that you have, you look at these graphs that the microbiologists have made, and then you sort of interpret it. And, if you're on orthopedics and your reg doesn't know what you're on about, which was what I had with my last job as a F1, I found it very difficult. So you need to make sure that you know your own guidelines. And yes, I do love orthoregs. And I really do. Once I finished my F1 job, I began to love orthoregs. Before I didn't like them, but no, they're very good. But they don't know much about gentamicin. Okay, last question. We are, before I go to the last question, actually, let's just see. Okay, now let's do the last question, and then I'll go through the questions in the chat and everything. So we have someone who is, this is really important. This is like super important. It's very important to know how to convert morphine and palliative care meds. Everyone gets very worked up about it. You will prescribe it on the ward round at 1 p.m. after you've had 6 hours of ward rounding. And then the palliative care nurse call you saying, oh, you didn't do this right, you didn't do that right, can you do that? Blah, blah. To be fair, they're very nice. They're very, very nice, the palliative care nurses. But when you're stressed out and you've got a lot to do, and if you start making all these prescription errors, it will just add up and will cause a lot of stress. So it's very important to get it right first time if you can. You could always aim to get it right first time. But to know the underlying principles of it all is very important. Sorry, I'm just really remembering my F1 days. Very stressful. Okay, so before actually let's go to the answer. So we'll just talk about it. So this person is on 90 milligrams 12 hourly of morphine sulfate. Yeah. So therefore, the total dose of morphine that they're on, yeah, is 240. Sorry, not 240. What am I talking about? 180. So 90 times 2 is 180. Yeah. So they want to change all that into a continuous subcutaneous infusion as a syringe driver. So what you're going to do is to get the 90 times 2, 180, and convert it into subcutaneous. Now, subcutaneous is double the strength of oral. So therefore, the total dose subcutaneously is going to be 90 because it's half of the 180. So therefore, answer here is 90. And you can actually probably figure out the answer from there, to be honest. And then how do you calculate the PRN dose? The PRN dose is 1/6, 1/6 of the total dose. So 1/6 of 90 is 15. So again, most of these calculations are very simple, but you just need to know the theory behind it. So again, 180 over 2, and then the PRN dose is 15. That's how you do palliative care dosing. And then, so that's what you need to know, how to convert from PO to oral, and then keep a chart handy for your exam or know where to find it. I think there's one on the BNF, if I'm not mistaken, but there may not be. I think this is from the BNF. Basically, it's just all these sort of conversions between these things. So, for example, 5 milligrams of oral morphine is equivalent to, 10 milligrams of oral morphine is equivalent to 5 milligrams of subcut IV IM. So that's kind of roughly how it goes. And then oxycodone, as we talked about, it's very important. Okay. Yes, questions. Let's go to questions. Oh, if you want to sign up to Quesmed, PSA 20 is the code throughout December. If you want to use it, 20% off. Please give me feedback. I'm really interested to see what you guys think because I've adapted this lecture compared to last year. I think it went well last year, but this year I think hopefully it was very smooth. I hope. You tell me what you think. And if you have any feedback on anything that we do, so either on the Quesmed, the website, the app, the lectures we give, the social media, whack it on here in the chat and we can talk about it if you want to stay behind and we can talk. I'm very interested to hear your thoughts, seeing as I have a lot of you in this virtual room. Okay, fine. So thank you for coming. For those who are going to head off, but yeah, I'll answer some questions now. Perfect. So do you have to put a specific number for the dose or you put a range? So you put in a range for the dose, but you put in the specific number, but the correct answer will fall between a range. So I believe, for example, for the furosemide 40, if you put in furosemide 40, it's correct, and they will accept, I think, anywhere between 20 and 60, for example, that sort of thing. Do you need to specify immediate release or modified release? Yes, you do, for whichever question it is. How do you tackle question 4 where there are so many doses to review, check against Bnf, but you're running against the clock? I would try and memorize a few of the key doses and the key things that you need to know. And then, but also, again, as I said earlier, you'll have a bit more time for those questions because some of the other questions will be a lot quicker. Obviously, it wasn't like 100% sort of time thing, time that you would expect in the mock test, in the actual test, but it's about preparation, I think, and also spending more time on the words. But no, it's about preparing and knowing where to find them in the BNF. I think those are the important stuff for the key stuff that you know. Epitropium also has constipation listed as common side effect, less common than the other stuff. So that's why it's sort of the most common cause. Fine. Would you get marks for saying wrong drug but safe correct dose instead of second line instead of first line drug? It depends. So sometimes they will accept the second line drugs if it is an appropriate drug, but I think you should really try and aim for the first line drug in the certain aspect. But again, most times it will be fairly clear, I think. I don't think they'll be too detailed in terms of guidelines. Is there a standard percentage mark needed to pass the PSA every year, or does it change every year on year? So it's done via a standard setting percentage, standard setting method, which is basically done according to the scores of everyone, the scores of each item. So one of the methods that we use for our mock test, which is mirroring what the PSA uses and also what the medical school finals normally use, is the modified Angoff test, which you can have a look at if you're interested in a modified Angoff method, and that will show you a bit about how it changes every year. So hopefully you can have a look and see, but it does change every year. Do you get to use a calculator? Yes, you can use a calculator. I think the calculator, built in. You had to add PRN morphine. Yeah, so I think in that question, there was no PRN morphine in the scenario, so that's why. Do you recommend learning drugs from the BNF? Yes, I would. Okay, and then let's go through. Okay, so people, okay. Is the gentamicin normal gland given in the exam? If yes, they would give it to you if they're going to show you. And then what about morphine the patient was taking the last Q? That counts the calculations? Yes. So if they're taking PRN morphine, then it will count into the calculations. Absolutely. Cool. Okay, fine. Okay, so we've answered all the Q&A. So let's go back all to the top. So feedback form is there. Thank you. Okay, let's go back all the way. All right, I think feedback form. Reg only speaks bone. Yeah. Hope you like that joke. Yeah, it's been a year in the making. Okay. Need to know detail pharmacology. Mechanism of action, don't need to know really, but you need to sort of have an understanding of it clinically. Yes. Feedback form. Slides is on the. Can someone share the link, please? I've lost the link to the slides for someone who needs it. Gentamicin graph. I don't know if it should be on the BNF, but I think if it's not, then they'll give it to you. Is subcutaneous dose double the dose for PO for every medication? No, just for morphine in this session, in this context. So more events. Do you guys want another mock test? I don't know, because I was thinking, because last year we ran 3, but they were paid mock tests actually. This year I'm trying to just do like free stuff because of the whole widening participation. I want to make sure everyone has everything available, etc., etc. Yeah, if you want another one, I could do it, but most of the content is already on the mock test on the site when they're out anyway. So hopefully that'll be useful, unless you just really like hearing me talk, which is fair enough. Joking.